It is a wonderful hormone. The second half of the cycle, which is when progesterone peaks, that's your calming hormone. That's when you look at, right, let me take it easy. You don't want to get injured. You don't want to be lifting very heavy weights. You look at more sort of the resistance training, your yoga, your Pilates, your stretching, and then you restart that cycle. So it's very important, especially for trainers, coaches, to see how you can optimize that athlete's performance based on where they are in their cycle.
One lifestyle that we see a lot is people that train very hard. So we see a lot of athletes, and I think there's been a growing understanding of the female athlete triad. So generally a high output with a relatively low intake, leading to hormonal changes.
Very interesting, my endocrinologist. I was telling my endocrinologist that we were doing podcasts on estrogen, and she was like, why do you need to know about that? You just touch feet for a living. You know, hopefully from today's conversation with you, we can show everybody why it's so important.
Welcome to episode 3 of the Best of Both Worlds podcast, the ultimate in health conversations, where we look to discuss, consider, and potentially find the humor in our quest as healthcare practitioners to optimize performance. That is sports performance, emotional performance, psychological performance, and just performance in life in general. I'm Matt Winter, Doctor of Physical Therapy with training in functional medicine, and I am here with Paul Macaulay, Senior Podiatrist, otherwise known on TikTok as the legendary Paul the Podiatrist.
Mate, I always enjoy that introduction about me. It's very, very special.
Of course it is.
But most importantly today, we have our first ever guest on the podcast. So I'll introduce her. It's Dr Tash Mirando, a British trained family physician who is known for her support of women's health, especially menopause support. Further to her women's health work, Dr Tash is also an accredited member of the International Board of Lifestyle Medicine. Dr Tash is located at Oslo Health International at Raffles Hotel Arcade Clinic. Welcome, Tash, to the Best of Both Worlds podcast.
Thank you so much for having me. I'm very excited to be here.
We're very excited.
We are excited.
Yeah, we are.
Yeah, very excited. Yeah.
So today we're going to be talking all things estrogen. And we have a tradition. It's only 2 episodes old, but it's still a tradition. How are you, Tash, out of 10?
I have to say, I'm going for 9 to 10 out of 10.
Wow.
It's big.
That's huge. That's a big one. Can you explain why, Tash?
Sure. I've actually been working hard to get my quality of life up. And for me, the key things, and the reason I even said 9 to 10 was actually I had a solid night's sleep yesterday.
Nice.
Because the night before I was up doing all of this prep work. So had to make up a little bit for it. I've also been to the gym this morning because if you've listened to the other podcasts with these 2 lovely gents, it's apparently a tradition to go to the gym before having the podcast. So I thought, you know what? Let's go.
This is misrepresentation.
Yeah, we've let the side down this morning. We focused on breakfast, didn't we?
We did, but we have to be fueled.
Yeah, exactly.
I've fueled as well. I'm ready to go.
Okay, now you're just showing us.
Yeah, exactly. That's why she's so great.
Yeah. How are you, Paul? Can you beat Tash's 9 out of 10?
No, I'm close. I was last week. It was, again, another tough week in clinic. And there were days where you saw me and I was like struggling. But again, prioritise my sleep. And yeah, I feel pretty good today. I'm just so excited. Always excited. And we got another new camera, which is exciting too.
That is exciting.
Hopefully take the editing to the next level. Yeah. How about you? How are you out of 10?
I don't know. I feel like I'm competing now. I'm going to say 8. I want to leave room for improvement.
Yeah.
But I had Chinese New Year last night with girlfriend and family.
What do you eat?
You know what I ate? I ate steamboat.
Yeah. And how are the joints feeling?
Vulnerable. Vulnerable.
Such
But no, I stuck to they were very nice. They made me some salmon just for me. I mean, I sound really difficult now. I ate the steamboat as well. No, I'm doing all right. 8 out of 10. That's good. All right, let's get into the nitty-gritty of this. Now, the reason why we're here today is because Paul and I were discussing that we noticed a lot of our patients are in a certain demographic. So they're 38, 55 years old, female a lot more than male, actually.
Yeah.
And we wanted to delve down into why that might be. So we had a thought about estrogen, and we think that that's probably got a big role to play. Now, didn't you have an interesting conversation with your endocrinologist.
Yeah, very interesting, my endocrinologist. I was telling my endocrinologist that we were doing podcasts on estrogen, and she was like, why do you need to know about that? You just touch feet for a living. And I said, I was like, I think it's important. But, hopefully from today's conversation with you, we can show everybody why it's so important. So Tash, can you tell us about your journey into lifestyle medicine and preventative health and well-being?
Certainly. For me, it all stems from sport. I think I was thrown in a swimming pool before I could even crawl or sit up. That followed a lot of training as a kid growing up, and a lot of gym time as well, actually, part of that. I then switched to tennis, and then I burnt out. Didn't touch a racket for 8 years. Played golf, which is what I was saying earlier. It took a little bit of learning not to smack every ball. And that actually really, really helped. And then it moved on from there with, I've been very lucky to be able to live and work in different countries. For me, I'm a die-hard NHS GP. So a lot of my principles, my values come from there. I still do my NHS work, keep my license going in the UK, in London. But actually starting work at Oslo Health International has really been able to elevate everything I love doing and to be able to offer that to our patients. When it comes to prevention, I'd rather that any day over waiting for something to happen and then have to manage it.
Yeah.
So a lot of conversations I have is about, right, it's not about where you are today, but I'm thinking 20, 30, 40 years. Let's think longevity. Let's think health span, the age until you're healthy. Let's think lifespan. It's not about everyone living to 100 plus. It's whatever age you live to, how can you have the best quality of life?
Yeah.
And hence how I thrive to have my 9s and 10s.
Yeah, yeah.
And to really optimize things, and especially things I enjoy.
Yeah.
For me now, it's tennis, and it's injury prevention. And it's being able to perform on a tennis court, not to get injured, and to be able to enjoy what I like doing.
Yeah, so you got to make sure that you're wearing the right shoes for the right sport as well.
Absolutely. I've already been told off for that, so definitely not making that mistake again.
And don't worry, I will be reminding you all the time. I think I'll be reminding anybody all the time. You want to explain to us, like, what is estrogen and why does it matter?
Yeah, certainly. It is a wonderful hormone, and it's there in men and women. So I don't want to park the men aside. I know you've got a wonderful guest coming in the future, so I'm not going to steal any thunder there. But with estrogen, it's a steroid hormone, and it's predominantly associated with the female reproductive system. It's produced mainly in the ovaries, but it's also produced in the adrenal glands. And this will make more sense as to why I mention this when we keep talking. It's produced by the fat cells and also the placenta during pregnancy. So 3 key types of estrogen. Estradiol is the main type, and that's produced mainly before the menopause and mostly by the ovaries. Estradiol is the main type produced during pregnancy, mostly by the placenta. And estrone, produced by the adrenal glands and fatty tissue, is the main type produced after the menopause. So all of this, and this is why I want to just go into that sort of root cause level, because it starts to make sense why some of the symptoms we have as women as we get older comes into play.
Fantastic.
Yeah.
And so what are some of the signs and symptoms of estrogen imbalance? And are there any that surprise your patients or even you to this day?
Certainly. Before I actually answer that, what does estrogen help support? Because for me, I like to have an understanding of where things are, so then it actually makes sense.
Yeah.
So it's female sexual characteristics, so puberty, breast development. It impacts your menstrual cycle, fertility, pregnancy, bone strength, maintaining cholesterol levels. This is how important estrogen is. And there's a reason I mention that, especially from what it does at a root cause, so looking at your muscle, tissue, ligaments, bones, is the leading cause of death for women, especially over the age of 60, is heart disease. What happens around that age, or just before, is the menopause. What happens during menopause? It's a drop in estrogen.
Does when you say maintains cholesterol level, do you mean that it keeps it high, and therefore cholesterol is somewhat protective in older women? Is that what you're alluding to, or is it just manages cholesterol levels?
So it's part of the pathway, the cholesterol and the lipid profile pathway.
Right.
Yeah.
Okay. So as that estrogen drops, what's the impact that we see?
So the
in that
lining
lipid pathway?
the lining of the blood vessels start to thin out.
Yeah.
And that can get clogged up by
Yeah.
certain types of cholesterol, which in turn results in atherosclerosis and then reduces the blood flow.
Right.
And can increase your risk of heart disease and strokes.
Right. Okay, clear. Thank you.
So looking at it from an estrogen imbalance point of view, I was sort of thinking, how do I break this down? Because for me, it's about making sense and it being logical.
Yeah.
So looking at it, it can be broken down into making too much in the body, getting too much from external sources, and then the body not breaking it down. So if we think about it as making too much, you're looking at conditions like polycystic ovarian syndrome, looking at obesity with a high body fat percentage. If you're getting too much, looking at the combined contraceptive pill. And if you're not breaking it down, what's your liver function like? What's your kidney function? Have you got chronic conditions that could affect this? Looking at it from a too little point of view, symptoms in the menopause, osteoporosis, which is the breakdown of bone, and that increases your risk of fractures. And I know this is something you were speaking of earlier as well, with the risk of falls and the risk of morbidity, mortality as a result of that, especially over the age of 65.
Yeah. All those like breaking of the hips. Yeah.
Yeah.
Such a high mortality rate with a fractured hip.
Yeah.
From a surprise point of view, and I am surprised that it is a surprise, is weight gain as we get older as women, especially going through the perimenopause and menopause. And this is where what I mentioned earlier about the fat cells, they do like estrogen.
Yeah.
And once it's in there, it's very hard to get it out.
Yeah. Yeah, I think that's really interesting for us because, a lot of stuff we've talked about in the podcast recently is like asking those harder questions about weight gain and weight loss. And that's something I've been asking over the last few weeks. And then when those like sort of older patients who have gone through menopause, are telling me that they've gained weight, then this knowledge, which we're hopefully going to learn today, I'll be able to apply this in future as well, this understanding.
I mean, it's not about excuses, and it's not about giving them an excuse, but at least giving them a reason, right? And that's very reassuring.
Yeah.
And I think when you can offer that knowledge as a healthcare provider that's not a family physician or an endocrinologist, it shows that you understand where they're coming from, and you're asking them for a reason so that you can educate, and you're not just asking because you're judging them. Can I just touch on Tash? You spoke about raised estrogen levels, and we spoke about some of the symptoms of lower estrogen.
Yeah.
In terms of elevated estrogen, what are some of the things that you might notice apart from weight gain?
Very hard to quantify because each person's an individual. So it might not be purely symptom-based, but it could be how it comes through with other conditions. So, for example, a low sex drive can be one of it. Irregular periods, changes in breast tissue, weight changes, fluctuations, and also increased risk of blood clot, stroke, inflammation in the gallbladder, and how you react to certain foods, stress, and alcohol.
Yeah.
Wow.
It's a lot.
So, I mean, you could make an argument for anyone that's had a cardiovascular event or a stroke to, okay, well, what are their estrogen levels? You could make that argument of delving that deep. I guess that's where a more functional medicine or lifestyle medicine approach might come in a more global assessment of someone's pathology.
Yeah. And I think what happened sort of 20 odd years ago with the Women's Health Initiative and the studies then that were done then was it was in older women, but it was once upon a time hormones were used very much from a prevention point of view, prevention of heart disease, prevention of osteoporosis. It then did a 360 and said, no, it's not good for you, don't do it. And now we're doing a lot more research to see not just from using hormone therapy in the menopause from a symptomatic management point of view, but in the future looking at it for the right woman from a prevention point of view. But we're still watching and waiting.
How would like alcohol and estrogen be linked?
It comes down to the breakdown of anything and everything. When you were younger, you probably could drink a lot more and process it better and be fine the next morning to get up and go.
That's what we also discussed.
I hear someone's got a birthday coming up. Is that right?
Yeah.
Or had it?
Yeah, no, it's coming up. It's
There
coming
you
up.
go.
Yeah,
The big 4-0.
Right, come on. I'm a young man. 30. Yeah, so hopefully, I will probably be recovering for a few days, I think.
I might need 2 weeks, I think, after that.
And it also comes down to what your baseline is. Are you a professional athlete? Are you a semi-professional athlete? Do you like to exercise? Do you not do any exercise? What do you do on a day-to-day? What's your work? What level of function do you need to be at? Mm-hmm. So it's about looking at that person as an individual and optimizing it for them as an individual.
Yeah, it's fantastic.
You mentioned that obesity and polycystic ovary syndrome was one of the things that might present or are examples of someone that might have a higher level of estrogen. Is there then a link between estrogen and sugar? Because it seems that sugar might be a common denominator between those two syndromes as well. Is there something to do with insulin and sugar that affects estrogen levels?
So it's to do with insulin resistance. When there's insulin resistance, the body has to work a lot harder to produce insulin to bring sugars down. So both in obesity, polycystic ovarian syndrome, the risk of diabetes, type 2 diabetes, is higher because of that insulin resistance. And a lot of that time is to do with abdominal and visceral fat. So weight loss, and I do this as part of sort of diabetes management as well, is you can technically, if with your type 2 diabetes, and you're obese, you could technically even reverse your diabetes by appropriate weight loss.
So we were already touching on lifestyle and how that can affect hormones. One lifestyle that we see a lot is people that train very hard. Yeah. So we see a lot of athletes, and I think there's been a growing understanding of the female athlete triad. So generally a high output with a relatively low intake, leading to hormonal changes such as amenorrhea, or the resulting being amenorrhea, as well as frequent bouts of colds and flus and gut issues. It's now been redefined as Relative Energy Deficiency syndrome. Yeah. Are there other conditions that we see in the younger population related to estrogen that is related to other lifestyle factors?
Very much so. I mean, again, you touched on REDS, and that's something that we've been seeing for years. It doesn't happen to everyone, and there's a lot of research being done in the area, but it's generally poor health and declining athletic performance when you're not fueling the body sufficiently. And you tend to see this more in semi-professional athletes because you don't have the right support network around you to make sure that for the amount you have as an output, you're actually being fueled and fueled correctly. So that's something I see quite a bit. Whereas when you get to a level where you've got a multidisciplinary team around you, all of that tends to be managed. And you learn a lot more about it as well. You mentioned amenorrhea, which is where you don't have a period for a certain amount of time, at least 3 to 6 months, which can affect your reproductive health. You then have insufficient estrogen, which can affect your bones, immunity. You mentioned lots of coughs and colds. It also does a 360 on your metabolism because it brings down your basal metabolic rate and health. It affects your heart and it affects your mood. So it starts this vicious cycle.
That's the link, isn't it? Low caloric intake. Those studies with persistent low caloric intakes have failed fairly often because eventually the basal metabolic rate drops and actually people put weight back on again.
Exactly.
Yeah, it's a really interesting tool that we can use to educate, because Tash, I've had a few conversations with patients recently who are coming towards the end of their sporting careers, and female particularly, where they worry that the tool that they had to maintain their weight, which was actually high-level sport, is now no longer going to be there. So that almost, and they've even phrased it like this, that kind of excuse almost to overtrain and take control of their body is now going to leave them. And I think it's really important that we acknowledge that there's a huge psychological component when we try and get people to refuel and rebalance their hormones. Is that something you've experienced as a physician?
Absolutely, as a physician, and also playing tennis at the level I play tennis, having a lot of friends come back from injury and expecting to hit the ground running at where they were.
Yeah.
And I also see it as a doctor from a patient point of view, is you were at peak performance for many, many years, either an injury or you retire. It's what do you do after? How do you get to a level where you can maintain your baseline, where you feel comfortable and you have that 9 out of 10 feeling every day?
Yeah, this reminds me of someone that's like who I used to live with, and she really cut back. She's quite very sporty, but she's supposed to come to Singapore, and she wanted to like lose weight. She really cut back, and she kept on training a lot, doing like CrossFit a lot, and then she kept telling me that she was putting on weight, but I knew she was barely eating, and then I think I've seen her go through a few of these things that you're discussing. So yeah, I think I'll be telling her to listen in.
Well, it's great that we can now potentially say that the under eating isn't necessarily serving them in their goals either. If their goal is to maintain a healthy weight, that's a great bit of info.
It's eating the right things and training the right way for you at where you are from an age point of view, goals point of view, and also thinking about the future.
Yeah. So what sort of things should they be eating?
Yeah. Protein and fiber, my two favorite things.
Yeah.
It's making sure that you optimize your protein goals. And this isn't about going out and having a steak every day and packing in your meats. It's looking at it from a plant-based point of view and building it from there.
Yeah.
So everyone says, oh, I eat a salad every day. What is a salad? What do you mean by a salad? Talk me through it. Break it down. Oh, salad. No. Let's talk about what you mean by a salad bowl.
Yeah.
Here's how you build it up.
Yeah.
Here's where you look at your green leafy vegetables, your cruciferous vegetables, your beans, your pulses, adding that on, looking at how much you're consuming, and also then saying, okay, where can I add to this? Can I look at things like tofu, tempeh, lean meats, fish, and building that up, because that'll keep you satiated and fueled for so much longer.
Yeah.
And it makes you feel good rather than, because you shouldn't really be going into any meal hungry. As soon as you start to feel hunger, especially during the day, it just means you haven't been fueling your body right.
And then you make poor decisions about diet as well, right? I think we're gonna delve a little bit more into the dietary and the lifestyle advice in a little bit. I think the most obvious, I'm gonna say condition, and for people listening, I'm doing that in inverted commas, that we see with women and girls that have started puberty. Is the menstrual cycle. And it's really great that as women's sport starts to become more publicized, it's on television more, there's more of a discussion around female health and the menstrual cycle itself, and how that impacts not just performance but injury risk. I saw a stat that women in sport often experience up to 6 to 8 times the amount of musculoskeletal injuries. And really interestingly, in the late follicular phase of their cycle, they have almost double the risk of muscle and tendon injuries. This is surely a conversation that we need to be having with our patients, which I have not been having.
No, definitely not.
And even coaches potentially need to be having. Is that something that you would align with? And what is your advice for coaches and healthcare professionals in having these discussions?
This is something that we have ignored for too long. It's something that's happening more and more from a conversation point of view, especially with female athletes. And also when you're looking at it from group sports as well. Unfortunately, you can't pick your event based on where you are in your menstrual cycle. So it's also then working out how you build to that and how you optimize what your performance is and where you can peak. Your peak would be different based on where you are in your menstrual cycle. So if you break the menstrual cycle down, we roughly say, okay, a 28-day, 24, 28-day cycle. Those first few days is where all your hormones are rock bottom and you're having your period. So you start to take it easy, you rest, you recover, and then you start to build. So those first 10 to 14 days when your estrogens and your testosterone really start to build up and peak is when you can start to lift your heaviest weights. You can really optimize your strength training. Whereas the second half of the cycle, which is when progesterone peaks, that's your calming hormone. That's when you look at, right, let me take it easy. You don't want to get injured. You don't want to be lifting very heavy weights. You look at more sort of the resistance training, your yoga, your Pilates, your stretching. And then you restart that cycle. So it's very important, especially for trainers, coaches, to see how you can optimize that athlete's performance based on where they are in their cycle.
So that second phase is the luteal phase. Is that what you're referring? Okay. Yeah. So you can increase load in the early phase, strength training, for example. However, then you get that high injury risk towards the end of that phase, and I think that must be to do with elasticity, and that feeds into that chat we were having earlier about hypermobility. Yeah. So you've got a hypermobile, and there's a lot of hypermobile patients we see here. Yeah. And then they're reaching that end of that follicular phase as well. They might be able to do strength training, is what you're suggesting, but potentially at that point, things like changing direction,
looking at more the stretching, the
plyometric type movements, that might not be the most sensible approach. Is that right? To clarify that? Okay.
Yeah. So it's very individualized. Yeah. So for me personally, I will see certain changes in how much I can lift, exercise, play sport, but it's not as obvious as it would be for someone else. So it's making sure it's that very individualized approach. And this is where a lot of watching, making notes, monitoring yourself, your symptoms, and this is where your nutrition can really play a part as well.
So I was very interested in what you're saying about sort of the menstrual cycle and how it affects like pain and injuries. And my girlfriend actually is a professional dancer. And something I've noticed is that her pain that she gets like in her shoulders seems to come in cycles. Like initially, like I thought it was to do like her workload, but now it's sort of changed a bit. And so, yeah, I just wondered like what I should be telling my girlfriend to do with regards to her like workload, because she can't really stop working for it. She needs to continue to train and dance to bring the money in. So what would you recommend?
So you can retire early.
Yeah, exactly. Yeah, on a farm.
On a farm. When it comes to, and this is from a professional point of view, is, as you said, it's very hard just to say, oh, I can't do that. But it's looking at it from a menstrual cycle point of view, where you are in your cycle and how you can optimize your training based on that. So this is going back to what we spoke of earlier, is really keeping a symptom diary. And I'm a big fan of this, because if you don't track things, if you don't write things down, if you don't see it and visualize it, it's actually very hard to convince people that something's not right. Yeah. So we use this, and this is where, for me, the measurables, the wearables, the tracking plays a huge part. Sometimes it can stress people out because you don't quite understand the data, but I think if you're working with the right healthcare professional, to be able to go, oh, hold on a second, you said, you weren't feeling great that day. Let's look back at your 24 hours. What was your previous day's stress levels? What was your core temperature? What was your baseline heart rate? Did you do any exercise? What was your sleep that night? Retrospect is a great thing, but then knowing that, moving forward, you can go, actually, I'm going to have a very stressful time at work over the next 2 to 3 weeks. I'm going to be very busy. How do I counteract that? What do I enjoy doing?
Yep.
So your meditation, look at it from an exercise point of view, your yoga, your conditioning, all of that. And it's very individualized.
Yeah.
And I always tell my patients, you know yourself better than anyone else. Don't let anyone tell you otherwise.
So, Tash, are there any other causes of low estrogen in younger women?
Yeah. When it comes to, one of the toughest ones actually is eating disorders, because you're in a fasted state or you're fueling and then it's coming out of the system, either in the form of vomiting, diarrhea. Looking at it also from something called pituitary gland disorders. It's a conversation in the brain, because a lot of things when it comes to hormones is a conversation between the hormones in the brain and then signaling the rest of the body. Chronic medical conditions, chronic kidney disease, genetic conditions called Turner syndrome, Fragile X, autoimmune conditions. So this is where the body is fighting itself. Looking at something called premature ovarian insufficiency. So very, very early menopause, where the ovaries just stop functioning, and then that conversation, no matter how much the brain signals the ovary to do something, including producing estrogen, it just doesn't happen. Cancer treatments, and I saved this one for last, is stress. Because I don't think people realize the impact acute and chronic stress has on the body.
Yeah, that's the thing like we've just been talking about like a lot, haven't we? We talked about it a lot in the last 2 podcasts, and then I've been talking about it a lot with my patients, and I asked them out of 10 how stressed they are, how stressed they've been in the last week, and like the numbers, mad. Like compared to me, I said like maybe I get to like 7 out of 10 stressed like once in every sort of 10 weeks. Yeah, it's just crazy.
And didn't you say that when they present it to you, they might say, oh, just normal really, so but 7 out of 10, and they think that's normal.
Yeah, but then, you know, there's been a few people that tell me it's 10 out of 10.
And so this is quite interesting, because when I was studying functional medicine, there was something we learnt about, they termed it pregnenolone steal, which was the idea that in periods of high stress, our body will go through the pathway of cholesterol being converted into pregnenolone, and then normally we will then get some cortisol, and we will get the HEA and our sex hormones. And in times of high stress, the body will preferentially create cortisol, and you will then sacrifice your sex hormones. Is that one of the things that's going on here when we're stressed?
Yeah, absolutely. So when the body is in this sort of continued, I'm not talking about a single episode, but it's when it's continuous. And unfortunately, it's a lot more common than we think. People are very good at pretending that everything's okay, or thinking that this amount of stress is fine for me to manage. You have to find alternative pathways to counteract that stress. And this is where nutrition, exercise, sleep plays such a huge part. But when this happens, so pregnenolone or progesterone steal, as the name suggests, is that cortisol becomes a priority over progesterone. So it skips that intermediate pathway of pregnenolone converting to progesterone, and it skips straight to cortisol. What is cortisol? Stress hormone. If cortisol is up all the time, because it has a sort of a cycle in the body, is in the mornings, and then it tends to calm and settle. So then your insulin, your other sex hormones can start to play a part. Whereas if it's constantly up, it's suppressing everything else. So your body is in a constant fight or flight response, which is exhausting.
Then how do you get to sleep?
That's right, isn't it? And then cortisol inhibits, I think, melatonin production,
so that
and then we
the
can't sleep.
circadian rhythm gets completely thrown. So there are things that you can do to counteract that, because a lot of the times it's very hard to tell somebody, what's the root cause of your stress? My work, I'm balancing a lot with a young family or with family members, parents being unwell. You can't tell them, stop working. Move to an island where you can just relax and farm for the rest of your life.
I think farming can be stressful as well.
There you go.
Especially in the UK, it rains a lot.
So it's looking at how do you balance that stress. And this is where looking at the 6 pillars of lifestyle medicine is using the other pillars to counteract and try and balance the stress, but also looking at it from, okay, my work, I'm in a very stressful situation right now. What can I do to mitigate that? What little changes can I make? Because something's better than nothing.
I mean, I think it's, like we spoke about in the last podcast, it's even about bringing awareness to that. Because if some people go through their lives not even being aware that they are stressed, and that feeling that they have in their gut or their chest is just normal to them. So you have to we can bring awareness to that and then intervene. We're going to talk a little bit more about interventions later on that.
Yeah. Fantastic.
So some of that lifestyle advice, it seems a lot of that lifestyle advice is about almost stimulating that parasympathetic part of the nervous system to calm the system down and allow for that recovery and better sleep. What about the other way? So that now there's a lot of talk about ice baths. That's being spoken about everywhere, isn't it, on social media? You're not a real man unless you get in an ice bath at 5 a.m. So what effect does that have on someone that's already under hormonal stress? I understand this concept of potentially trying to get a cortisol spike in the morning, because some people with prolonged stress, I think, have lower cortisol in the morning. But does that then have, are we going about it the wrong way around here? Or is it quite safe to try and get that cortisol spike when someone is already struggling in that overstimulation of the sympathetic nervous system?
I think this is a very grey area, because there's no right or wrong answer. It's not black and white. I can't say, if you do this, you're going to feel like this. It's very individualized. And the response I give to 10 people with the same symptoms will be different, because it comes down to what their baseline is, what are their goals, what do they do on a day-to-day basis. So it's not as simple as, if you do this in the morning, you're going to feel great. Few things that you can do first thing in the morning is to get some sunlight, because that just sets your circadian rhythm and it tells the body, okay, you're up now, you've got your sunlight in, let's go.
So we've spoken a little bit about nutrition and lifestyle interventions. There is a group of people that potentially need a little bit more specific advice, or this is the idea that we have. So this is women that have encountered estrogen-sensitive cancers. I think in the past they've been warned away from certain food groups that contain phytoestrogens, so tofu, soy-based products, for example. Is that advice something that has stood the test of time, or are you giving some different advice these days?
Again, this is very individualized advice, because it comes down to what type of cancer or condition, what treatments were provided, and that can change. So again, this should not be a black and white answer, and I want to make that clear. With phytoestrogens, these are plant nutrients found in several different types of foods. So your soys, your grains, your beans, certain fruits, cruciferous vegetables. But actually, there's evidence to show, and this is where we'll put a link to the show note, is through breast cancer prevention partners, a lot of evidence there. When consumed regularly during childhood, so especially looking at this part of the world, there have been links to a decreased risk of breast cancer. So Asian versus Western diets. Also in the postmenopause phase, estrogen can have better protection, but it comes down to what treatments people have had. So I don't think it's as clear-cut as should you or shouldn't you, but the beauty of all of this is there's a lot more research being done. So actually, if anyone's really interested to know the nitty-gritty, we'll put a link to the show notes as part of Breast Cancer Prevention Partners, where all the papers, the research, the data is in there.
That's super interesting. And so it implies that these phytoestrogen compounds can have a potentially protective effect, but also that they actually do have an effect on estrogen levels. In that case, is that part of the advice that we can give to patients post-menopause or during perimenopause if they want to naturally increase their estrogen levels? Is that something they can do?
Absolutely. And I wouldn't even say it's perimenopause, postmenopause. I'd say at any point you can actually use nutrition from a cycle point of view. So in that first part of the cycle, really focus on how you can get more of those phytoestrogens in. Looking at it from a testosterone point of view. Now, progesterone and testosterone, there aren't direct foods to increase it, but there are foods you can have where the body can then help to increase and improve. So that's something I have regular conversations with patients about, and it's part of the information I share with them after. Because a lot of the time it's not just about what treatments you can use. I always say optimize your baseline using your lifestyle measures, and then you build from there. Because if you don't have a solid baseline, I can throw medication at you, but it's not going to have the best effect.
Pull the big levers first, I think, is the message, right? Yeah. So that's a way to increase estrogen levels. I believe there are other food groups that we can use to reduce estrogen levels as well, potentially. And there is some talk about cruciferous vegetables containing a chemical called indole-3-carbinol that may have anti-estrogenic effects. Is this a real thing here? And is it something that we should be concerned about, or is it something that we can actually use?
Okay. So let's start with what is indole. Okay. So it stimulates the detoxifying enzymes in the gut and the liver. And actually, in certain studies, it has shown to slow down cancer growth or enhance some of the chemotherapy drugs. Now, again, using this is very individualized. So I talk about indoles, especially when I talk about gut health and gut health testing, and it's looking at it as an overall picture. Now, the general consensus is it's safe to use in the amounts we have in our diets. If you're using it as a supplement, which we spoke of earlier, I would say always talk to your healthcare professional first, because it's not just about, chances are if you're thinking about supplementing with one thing, you're on quite a few other supplements.
Yep.
So it's just making sure that you are using what you need rather than.
Can you give us some examples of cruciferous vegetables?
Come on, Paul.
I'm dyslexic.
So we're looking at your broccolis, your cauliflower, your Brussels sprouts, all the good stuff that you can build. This is why I always ask my patients when they say, oh, I have lots of vegetables or I have lots of salads. I say, right, I need to know what you have in there.
Yeah.
What is a salad to you?
Yeah.
Because having an iceberg lettuce, doesn't constitute a salad. And a little bit of carrots in there.
Just copious amounts of dressing. You go to cold storage to get your salad, and wow, the dressing inside, yeah, please. And then it's like, where's my salad gone?
So can I have some salad with my dressing?
Exactly.
Oh, that's so interesting. So we can potentially, so we spoke a little bit earlier about conditions where there are high levels of estrogen in women. So again, the flip side of what I said about tofu, we can potentially advise or counsel or refer to a nutritionist to suggest dietary interventions for those conditions. So, for example, PCOS, for example. Is that something that you
and
suggest?
again, from a polycystic ovarian syndrome point of view, balancing out your sleep, your nutrition, and exercise that works for you is key.
Yeah, that's the cornerstone.
These
are the bonuses, right?
Correct, yeah.
So should we move on to a big topic, which everyone, I'm sure, will want to hear about, and I think affects a massive amount of our patient group. So we'll talk about menopause. Will you be able to enlighten us to the role of estrogen depletion in reduced tissue integrity and pain modulation?
Yeah. More than 50% of the world's population will go through the menopause. We're women. It's a natural process, but it has a huge effect. So we need to think about it. We need to prepare women and also educate women so that they can make an informed choice. It's not about everyone doing the same thing because we're all individuals. Specifically, thinking about pain, there was research done by Low and Kin et al. A little bit, it's about 20 years old. However, in Singaporean women, the number one complaint going through the perimenopause and menopause is joint and muscle pains. So I wanted to tie that in to your ongoing conversations with the podcast, and then that is followed by lethargy, so tiredness. Also looking at it from an average age of menopause. So what is menopause? Menopause is a clinical diagnosis where you don't have a period for 12 months. Yes, there are instances when we have to do hormone tests because each one's individual. You could have contraception in place, etc. But generally speaking, we use it as a clinical diagnosis. In Caucasian women, that age is 51. Women in Singapore, Southeast Asia, it's 49. In South Asian women, it can be 46, 47. So when someone comes and tells me, oh, they're too young to be going through anything, especially when it comes to perimenopause, it's not an age factor.
What's the youngest you've seen in your clinic in terms of patients going through menopause?
Yeah. To be honest, with POI, which I mentioned earlier, had women even in their late teen years, early 20s. In Singapore, if we're looking at it just from a natural menopause process, I have women starting in their mid to late 30s going through symptoms. Because with the perimenopause, the average timeline is 7 years. But it can go on from anywhere between 5 to 15 years, which is why I don't like using age as a factor.
Yeah. And so what are some of those symptoms that we can look out for as healthcare providers? So we're seeing a lady come into our clinic with a gradual increase in the amount of symptoms they're seeing. We've ruled out other key structural components.
That's very
and
important.
Other causes and red flags. At what point do we start considering hormones as a contributing factor? Is it the classic hot flashes, change in sleep, maybe some mood changes? What are some of the things that you would look out for?
Okay. We probably have over 80 symptoms.
Okay.
We use core symptoms, and one of that includes muscle and joint symptoms. It's looking at it as an overall picture, and I think for the two of you, you'd see a lot more of that MSK type symptoms. As you mentioned, Matt, the key thing is to rule out other organic causes. It's not just assuming, oh, this is the perimenopause, or the other way around. Oh, we've ruled out the organic causes. You just need to continue doing your physiotherapy and strengthen, and you'll be okay.
Yeah.
So it's important first to look at root causes, rule out any other causes, and then go, right, let's look at it from a 360 view. What other symptoms are you actually having? And this is where I use a menopause symptom questionnaire, because a lot of the times women don't associate some of the symptoms with possibly going through the perimenopause. So it's putting it all together. So I spend a lot of time just sitting and listening, because history is 80%
exactly.
of
80%.
80%.
Well, I say 70, didn't I? Before?
I said 60. So my question is maybe not good
80% is good history taking and listening.
So it's quite interesting you said other organic causes. Just off the top of my head there, I was thinking it could be thyroid issues.
Absolutely, yeah.
Iron deficiency, anemia, which is another women's health issue there. So I guess we need to go through that whole process first.
But it's also when you mentioned about thyroid, iron deficiency, and anemia, could heavy bleeding as part of the perimenopause be either caused by thyroid dysfunction or result in iron deficiency and anemia?
So you've got two things happening together. And that's that rule in medicine, isn't it? Just because you find one thing doesn't mean there's not another one.
Yeah.
Not to scare people. But so many these things are interlinked.
Are there any questions that you think that we should ask our patients, maybe when we're thinking it could be that, and maybe how we should word it? Because we are two men And now the ladies may be a bit taken aback.
And you're right, and I think that's the difficult part, is the assumption is you don't know anything when it comes to women's health. But I think the more you have a conversation about it, and you get to know your patient, it's building relationships.
Yeah.
They trust you, they listen to you, and it's saying, okay, have you thought about this? Why don't you go read a little bit about it, and then think, oh, actually, maybe fill out a menopause symptom questionnaire, and then think, right, what's the next step? Who do I go and see in order to get the help I need?
Yeah.
But I think questions-wise, especially if they're coming in with joint symptoms, it's looking at the other symptoms. So yes, the most common are your hot flushes, your night sweats, but it could be anxiety, mood changes, brain fog, reduced sex drive, changes in your hearing, tinnitus, which is ringing in your ears. But that is where you just sit and you listen. Or you signpost people. You can't do everything.
I think
So it's signposting then to who can actually have that conversation.
I mean, sometimes I just hit it on the head. And I say, look, you've explained to me a lot of issues that are going on here. Sometimes hormones can play a great role in this. How are you? How is everything hormonally? When was the last time you saw an endocrinologist? When was the last time you checked in with your family physician about hormones? Are you regular at the moment still with your menstrual cycle?
Yeah.
Is that an appropriate question to ask?
Absolutely.
yeah.
Yeah, and I think there'll be some women who look at you going, what do you know about a menstrual cycle? But there'll be others who say, oh, actually, thank you for asking me that. Thank you for helping me to think about it and have that conversation.
I have to say, so far, I've never had anyone react that way. And
Brilliant.
most of the women look at you like, oh, wow.
Yeah.
Wow,
Yeah.
you're actually thinking about that.
Yeah.
As a guy, maybe, and then as a physiotherapist as well. So, brilliant.
And
We
it
will
and it
carry on.
shouldn't be the case that this is a female doctor versus a male doctor, or physiotherapist, podiatrist, whether you're male, female. It shouldn't matter.
Yeah. Yeah.
The learning and then improving your learning and building on that should be done by everyone.
Yeah. I think I'll first practice on my mum. I'll call her up and ask her about everything over the years. See if she can tell me some stuff, and then I can educate her.
First got to get her into the gym, I hear. So
Yeah, she does. She does have to get into the gym. Yeah. Don't remind her. Do you know what? I told her that I'd mentioned it in the last podcast, and she went, "Oh, not again," because in the first podcast we talked about how I used to go to bed at 7 p.m. My mum used to send me to bed at 7 p.m. and she kicked off saying, "That's so not true. That's so not true." And I was like, "All right, mum, 8." And she was like, "Oh yeah, okay, 8. Still a little earlier than 10 p.m., isn't it, mum?"
I felt bad because when I watched back, I did an impression of my mum as well.
You did, yes.
I actually think I did her voice. I felt bad about that. Hopefully, she's not going to hear it.
Don't send
That's
it to
one
the family
listener we've
group
lost.
chat.
Okay, let's go back because I think the original question was, what is estrogen's effect on pain and tissue integrity? I had a brief look at this, and it seems very complex. There's a concept of it interrupting the opioid mechanisms in the body, and it's something I've discussed quite a lot with patients, in that they just say, I just hurt more. And it does seem tougher when we do the same things with different patient groups to get quick results in this group of patients. So I believe, and I'm not sure if you know anything about how estrogen interacts with the opioid system. In terms of tissue integrity, it seems that estrogen can have an anti-inflammatory effect and a pro-inflammatory effect as well, and it's really nuanced. Do any of these ring a bell with you?
Yeah, I mean, it's going down to what it does. So at a cellular level, you're looking at it playing a vital role in skin, tissue, and bone development. Estrogen's the sexy hormone, right? And I said I would say it.
Good. Good for the socials.
Progesterone's a calming hormone, and testosterone basically builds on everything. With pain regulation, it actually acts at an intracellular receptor level, and then it can actually modify gene expression, and then the proteins along the central and peripheral nervous system, as well as you mentioned being a pain modulator at various other pathways I'd love to say I know more to go into more detail, but I'm afraid that's above my...
So as long as we know, it's involved in this health of the central nervous system, and it's involved in pain modulation through the opioid pathways. I think that's enough, and that's what people need to know, is that we're slightly altering the body's own drug cabinet in terms of managing pain and tissue sensitivity potentially.
Yeah.
And then in terms of healing, actually, Paul, you'll be quite interested in this. I saw, we spoke about protein affecting wound healing.
Yeah.
It seems there's some research now looking at estrogen as almost a treatment in encouraging wound healing, I think even in venous ulcers and arterial wounds.
Especially in diabetics.
In diabetics. Is that something that you've looked into?
And this is where the research is coming in about using hormones from a prevention point of view. Because at the end of the day, it's looking at it from a baseline or root cause level, and how can we manage things in the safest possible way. We mentioned earlier about estrogen and how it can be suppressed with chronic conditions. Diabetes, chronic condition.
So as a podiatrist?
Yeah, very interesting. I would say, actually, my wound care wise, I see a lot of men for wounds. Yeah, not as many women.
Do you think this is really out there? Do you think that that's because women take greater care of their peripheries, and actually, because so many of those wounds are because they don't notice them early and they don't manage them early, and they end up coming to you because they're wounds that need debriding?
Yeah, exactly. Yeah, I think that's probably big part of it. Ladies do tend to, especially in this part of the world when you've got your feet out. More, they'll look after them better.
So a lot of those diabetic wounds are down to sensory issues. They're not feeling them.
Yeah.
And I think I'm going to hazard a guess, men are just not as good at checking.
And it's also the neuropathy can present differently. And the risk of chronic conditions, especially for men who are going to be overweight, obese, having other chronic conditions, the amount of alcohol consumed, food, fats, etc., especially, I have to say, this part of the world, you tend to, and as you said, you just ignore things until it becomes an issue you feel you have to deal with.
Yeah, I think I've oversimplified it a bit, but but it's a thought. So we've spoken that estrogen potentially has a role in opioid mechanisms, in tissue inflammation and wound healing. Something that we deal a lot with is joint issues. There is some research emerging in that area, or I think it has been talked about for a while, estrogen and osteoarthritis.
Yeah. So with estrogen, it's actually from a prevention of osteoporosis. Now, osteoporosis doesn't cause pain, but what it means is the integrity of the bone has just gone. And so your risk of fracture when you fall, or even without a fall, is much higher. That's where then the pain comes in. Whereas osteoarthritis, anything to do with the bone, unfortunately, doesn't seem to be, in this paper that you had shared, so Fenton and Panay, it says it's an unsexy area of medicine. That, again, is for you, Paul.
Yep,
But it's debilitating, especially with osteoarthritis, where, especially in your peripheral joints, and you need your fingers for most things.
and your big toe.
And your big toe, there you go.
Very important.
Yeah. So it's really looking at it from how do we reduce the effects of pain, because pain, again, can have such a detrimental effect to your mental health and well-being, and it becomes this vicious cycle again. And then you avoid exercise, yeah.
So we've spoken about estrogen in its role in opioid, in the opioid system, and we've spoken about it in its role in inflammation and wound healing, and now osteoporosis. I believe there was a study looking at osteoporosis that actually found as a secondary measure that in women that had been taking HRT for more than 10 years, they actually were protected against osteoarthritis of the hip. Is that something that's getting more established now, that understanding of estrogen with osteoarthritis as well?
I think, yes, there are a lot more studies being done. Unfortunately, we're still not using it from a prevention point of view, other than looking at it from osteoporosis. But osteoporosis is breakdown of the bone and its structure, so there's no reason why it can then help with the bone formation and protecting against the general wear and tear. And with osteoarthritis, it kicks in from about the age of 30, 35. We start to get general wear and tear. So we all have an element, well, nearly Paul, but we all have an element of wear and tear.
You'll get there.
Well, you've definitely got it, haven't you, old boy?
I have. There's certainly estrogen receptors in cartilage, right?
Yeah,
So
absolutely.
it would make sense as well. Okay, so another group, aside from menopause, another group that might have reduced levels of estrogen are patients that have had cancer that are then put on medication to reduce levels of estrogen. So I had a patient yesterday on letrozole, for example. So I think they're either on aromatase inhibitors or, as you mentioned, SERMs. In this group of patients, first of all, is this link with pain established? And secondarily, is there anything that they can do to counter that? And is it safe to try and modulate that at all?
I would say the safest is to optimize your baseline with your sleep, your nutrition, your exercise, especially that strength training side, and coupling it up with protein and the right fibers as well. Depending on what medication you're on, it can compete if you're over-consuming phytoestrogens, for example. But this is, again, that conversation within a very multidisciplinary approach, looking at, yes, the oncologist with treatments, but also with the nutritionist within that area to say, right, here's where you need to focus on.
Okay, so to be clear, do the pillars and then potentially look at phytoestrogens in some of those medications, but that needs to be done with your oncologist
Absolutely.
and nutritionist
Absolutely.
and the whole team. Brilliant. And that kind of links us on to pharmaceutical interventions. So post-cancer and cancer aside, and just in patients going through menopause, HRT. There's a lot of information out there. I think there's a bit of a misinformation as well. So I just wanted to get your overall views on HRT. When is a good time to start it? Is it ever too late to start? And in these patients that have gone through estrogen-sensitive cancers, are there risks?
Okay. So let's talk what is hormone therapy. All we're doing is giving the body back what it's lacking and what it needs. At the moment, hormone therapy is indicated for your vasomotor symptoms, so hot flushes, night sweats, vaginal dryness, and also in certain mood changes, brain fog, and osteoporosis prevention. When it comes to cancer risk, and this is what I really wanted to go into a bit of detail, is yes, there's a lot of misinformation out there. Let's put it into context. 1 in 4 women who have breast cancer can be preventable via lifestyle choices. So if you're obese, if you smoke every day, if you drink more than two glasses or more of alcohol every day, your breast cancer risk is higher than if you were on hormonal therapy. Age is the other biggest risk factor, which is why at the moment we say with hormone therapy, you have it within 10 years of going through the menopause. So it's important for women to see and feel the changes they're going through and to get the help in time. I'm not saying hormone therapy is there for everyone. It is a personal choice. It's there to manage the symptoms, but there's also the benefits that you don't see. So improving your bone health, reducing your risk of chronic diseases, heart disease, Alzheimer's, dementia. And it's not just about the estrogen, it's looking at the progesterone, which you need if a woman still has their womb, because you have to protect the lining of the womb, because unopposed estrogen otherwise increases the risk of womb cancer. But also not forgetting testosterone. It's aiming for that quality of life with what you need, which is why, for me, the overall benefits when it comes to hormone therapy for most women outweigh any risks. So symptomatic management, looking at that long-term benefits versus risks, should also be accessible to everyone. And then it's a personal choice after you've been educated on all the information. And it's about that quality of life as well.
So specifically in terms of timing, does it matter how early or late you start? And I think there was some concerns about blood clotting in the use of late HRT. Is that a thing?
So with blood clots, it really comes down to the type of hormone therapy. What we're using now is transdermal, meaning through the skin, so as a gel, as a patch. The progesterone, and with the estrogen as well, it's body identical, so it's as close to the body's hormones as you get. Progesterone, you can use that Merina Coil, especially when there's heavy bleeding as well, or Utrogestin, which is a micronized progesterone. Using hormone therapy in those two forms, there is no evidence to show that there is an increased risk of blood clots, especially in the first 5 years of use. And also moving on to breast cancer risk, it's the same with that. So it's constantly looking at risk versus benefit. The other benefit with hormone therapy is that chances of you being up to date with your screening is much higher. So your breast screening, your cervical screening, keeping an eye on your bone density, which means the pickup rate of changes, cancer, is early. So there's no evidence to show that the risk of death of breast cancer being on hormone therapy is higher.
And you briefly touched upon the Merina Coil. Could you tell us a bit more about what it is?
Certainly. So we use it as part of long-acting contraception. So it's a little coil that sits in the womb. I do it in clinic. I have colleagues who do it as well. And what it does is it protects the lining of the womb, and it's very localized progesterone. Some women will say, oh, I can still feel the effects of progesterone in the body. So a little bit of acne, breast tenderness, mood changes. But this is as localized as it gets. It protects the lining of the womb. And it can be used for between 4 to 5 years if you're using it as part of hormone therapy. You can then add on estrogen in the form of transdermal, a patch or a gel. And depending on symptoms, especially a very low sex drive, which is what it's licensed for, we use testosterone for women as well.
And I think we mentioned off air that the coil can also, because of that progesterone release, prevent that heavy bleeding. And therefore, that for our athletic patients as well, that are struggling energy-wise, potentially because of blood loss and anemia, a coil potentially could be an answer to that.
Comes down to the level of performance as well, and keeping a track of the coil, because there is, especially in the first 6 weeks, there is a chance of expulsion, and it's something that we just monitor and we keep an eye on.
So, just that last question on safety. If a female has had an estrogen-sensitive cancer in the past, can they take HRT if they are now struggling with quality of life and function because of the secondary effects of low estrogen?
You hit the nail on the head there. It comes down to function and quality of life. And this is where really proper conversations need to take place about risk versus benefit. I know a lot of women who have been through breast cancer and have said, you know what, I appreciate the risk is higher for me going on hormone therapy, but my quality of life is just rock bottom and I'd rather take that risk. And I have others who say, no, hormone therapy, never having it. It's probably what caused my breast cancer. I'm done. I will manage elsewhere. But either way, having that good baseline to build on is key.
Brilliant.
Yeah, got to have open conversations.
Absolutely. And there are options for localized estrogens for things like vaginal symptoms and things like
yes.
that as
And
well.
I have to say I'm really happy to see, even in Singapore, where oncologists are in agreement to use localized estrogen in the vagina for vaginal atrophy. Because again, when it comes to quality of life, recurrent urinary tract infections, feeling uncomfortable down there, low sex drive, not wanting to have sex because it's so painful when you do, we can really improve those symptoms.
And then second, for us, that can lead to pelvic floor muscle issues and then back pain and sacral pain. That's something we see in clinic, right? So it all kind of links together. Advice. So aside from HRT, for menopausal women, I had a look at the advice that the Institute
So the British Menopause Society and the Women's Health
Women's Health
Institute.
Initiative,
Yes,
right?
Institute. Yeah.
Institute, sorry, gave. And I noted that they recommended a lot of Zone 2 exercise, so swimming, cycling, and things like that. They didn't mention strength training at all. I was quite interested in that. What's your thoughts on that?
Strength training. Lift heavy weights. This isn't about, oh, I lift weights. What do you lift? What do you do? Do it safely. There's lots of options to start with body weight exercises. The reason for this is really with zone 2. And when people say, oh, what is zone 2? It's where you can talk, but you can't sing. So you can walk at an incline on an incline on a treadmill. You can cycle. You can use your cross trainer. You can go for a walk. And I say walk and talk. It's the best way. You're killing 2 birds with 1 stone. You're getting your zone 2 in, and you're fixing your mental health and your social connectedness as well. So it's a great way to build on that, because also going through the perimenopause and menopause, there's a lot more storage of fat, and the estrogen likes to be in there. So it's converting that fat to muscle through optimizing your protein, your fiber intake to balance it out, getting good sleep, and looking at all the 6 pillars. If you smoke, stop smoking. If you drink alcohol, cut back, because you will see the effects and the benefits it has on you.
You can never sing though, so
I can't sing.
You can't use that.
Leave that to the girlfriend.
What about? Yeah, the other way I've heard zone 2 is you can talk, but you'd rather not.
Okay.
Which is quite nice
That's
as
it.
well.
But Tash is encouring them to
I'm encouraging
call people
talking.
Yeah,
down the
true.
phone.
I see that now.
Walk and
Yeah,
talk,
great.
I'm calling.
Walk
I've
and
coined it.
talk. Yeah, we'll keep that then, Tash.
Yeah. Do other sex hormones such as progesterone affect this group and therefore pain and function?
Absolutely. With progesterone, we call it the calming hormone. So this is why that sort of week before your period is when you look at taking it easier, doing more of your stretching, your yoga, your Pilates. Need a bit more carbs in your lives, right? It's looking at it overall and fueling the body so that it's getting ready for either pregnancy, if you fall pregnant and then the progesterone stays high, or if you don't, it comes crashing down and you start to feel, ugh. I mean, I have no other way of explaining that. And then that's when all the hormones sort of drop down. But it has also been shown to reduce neuropathic pain involving nerve damage and various other benefits as well. But this is where we shouldn't be pushing the body, because this is the time for the body to rest and recover. When it comes to testosterone, it's an anabolic hormone, and it can build strength and muscle. But it can also, and Matt, you touched on this earlier, is it can reduce inflammatory markers, so that the body is, the more inflammation, so inflammaging, so the more inflammation we have in the body, it actually can change the way we function and the recovery process as well post-exercise.
Nice.
So there's potentially a role for testosterone therapy. Is that what you're suggesting?
So with testosterone, it's currently licensed for women who have very severe, very low sexual function, low libido. That may change in the future. And it's also getting the right testosterones and getting it at the right level. So it's not something I would say we go straight for, because throwing the kitchen sink at something and then not knowing what is actually working. So it's about building it up.
And there's other ways of naturally increasing testosterone as well.
Yeah.
Same 6 pillars, isn't it?
Same 6 pillars and nutritionally as well.
Tonka Alley.
While we're on testosterone.
We're on testosterone. What is andropause, and is this purely related to a reduction in testosterone?
Andropause is, in a sense, a male menopause, okay? But it's different because it's not something where the hormones just come crashing down like it does in women. Some men can develop depression, loss of sex drive, erectile dysfunction, and other symptoms, and it tends to be sort of late 40s and 50s. A lot of it is to do with lifestyle factors, so lack of sleep, poor diet, lack of exercise, excessive alcohol, smoking, low self-esteem, also resulting in, and this is where the vicious cycle kicks in, obesity, type 2 diabetes, and other chronic conditions. From a medical perspective, you can have something called late onset hypogonadism, which is where the testes produce few or no hormones. So again, we're first looking at ruling out organic causes and then going, right, how can we manage this?
So we've noted sex drive might be a change. They might notice potentially more apathy in their life in general. What are some key symptoms that a man going through this process might present with?
Very similar to women. So brain fog, tiredness, sometimes hot flashes and night sweats. But I think key things that men would notice would be that low sex drive and just fatigue. So it's looking at it going, okay, could this be stress related? Could this be pure nutrition? And then optimizing all of that, but also looking at what can it be organically. Could be your thyroid function. And we don't talk enough about organic causes in men, but look, checking the thyroid, checking iron levels, vitamin D levels, all of that.
Nice. And as we are talking about estrogen primarily, can men have imbalances in their estrogen as well? So can we have a situation of, say, estrogen levels being too high in men? And how does that come about?
Yeah. So this is where looking at it from a low testosterone point of view and a raised estrogen. So low testosterone, we've mentioned certain symptoms, including sort of depression, anxiety, low sex drive, mood swings, etc. And that can play a role in musculoskeletal symptoms. So they might just present with chronic joint symptoms. And that's something to really keep an eye on. Raised estrogen, generally speaking, we mentioned the sort of main three types of estrogen. And for men, it's that production in the adrenal glands, in the fat cells. Men need a little bit of estrogen from a function point of view because it stabilizes muscle mass, preserves bone strength, and actually maintains the nervous system as well. But if they have a high level of estrogen, either it's being overproduced, something's being taken externally, or the body's not breaking it down, just like I mentioned for women, you could have things like gynecomastia, which is the medical term for increased tissue in the breasts, infertility, erectile dysfunction, and depression. So it could present that way. Now, seeing gynecomastia is not that common, but when you do, you'll never forget it.
And is there a link between obesity in men and that high level of estrogen? So again, there's lifestyle factors that can lead to that.
From a research point of view, I wouldn't be able to comment. It's not something that I've looked at in too much detail. But again, with obesity and raised body fat percent, possibly. Would I go doing tests on it? No.
Wow. What a discussion. It's sort of hard to know how to summarize that. So I think probably the best thing that we can do is get Tash to summarize that. Tash, if you could leave our listeners with 3 key points to go away from this and hold on to and use regarding estrogen, what would they be?
I like to simplify things. I like to understand, and it needs to be logical. So I've broken it down into 3 parts. So my first take home is educate yourself. Understand how estrogen and other hormones impacts your body. And from a day-to-day point of view, how it impacts you specifically and what your goals are. Once you educate yourself and you have that level of understanding, do something about it. There's no point knowing and going, oh, that's interesting, and then just going on a walk and talk. Use estrogen and other hormones when it's needed. Use it at a dose that works for you in its most body-identical form, so the safest possible way, with continued monitoring by your trusted healthcare professional. And after that, you stick to it. Be consistent. Keep optimizing your lifestyle pillars. Be a little bit selfish. And I tell my patients, I said, I'm here to make you a little bit selfish. And it's not a bad thing, just a little bit. Because as women, we're very good at looking after everyone else. But we tend to forget ourselves because the priorities are work, family, everything else, friends. And then I'll think about myself. So just be a little bit selfish so that you have a solid baseline for everything else and you can thrive.
Yeah, very good.
I'll argue with that.
Yeah. Yeah, it's fantastic, isn't it?
I was just saying, wasn't I, before about my mum?
Yeah.
Just priorities everyone else, apart from myself.
Yeah.
Thank you very much, Dr. Tash.
My pleasure.
So I think I'll be having a chat with my endocrinologist, telling her all these things that I've learned and why it's so important. Yeah, it's been so good to discuss this, and hopefully, like, this is something I can take into my clinics and have these conversations with my patients.
My pleasure.
So, move on to these are our favourite segments of the podcast. Something a bit more relaxed. So usually for like our therapy, we like to talk about one pet peeve of our profession. So if you want to give us one of your profession.
Certainly. I think for me, it's when patients don't feel heard or listened to. And they come in and see me. Because I'm very lucky because I get to see a lot of complex medicine, lifestyle measures. And it's when I sit back and listen. And I have the privilege of time here. On the NHS, I have my 40 patients a day. It's a little bit harder.
It's immense. 40 a day. That would kill you, wouldn't it?
But I think it's just listening and building that relationship. But I think when patients come in and say, I just don't feel like I've been listened to or heard, or this is the first time I felt someone's listened to me, that makes me just a little bit angry.
The beginning of the healing process is certainly being heard.
And again, subjective assessment.
And getting
just
a good subjective
so
assessment.
important.
Huge.
Yeah.
That's a great one, Tash.
So now on to our favourite segment, the magic wand segment. Not like that. So this is where what do we do?
This is where we share our wish for our patient group.
All over the place.
Or the whole of society.
Yeah.
So Tash, you'll go. Magic wand.
Prioritize sleep and nutrition. Lift heavy weights safely. Manage stress early. And go for gold when it comes to improving your quality of life.
Yes.
Brilliant. It's almost like she's listened to the first 2 episodes.
Yeah.
Podcast, isn't it?
Had to do my research there.
I wonder why I wanted to get her on. 'Cause she sounds just like you.
Flattery is the... No. Wrong way around. Mimicry is the highest form of flattery, right?
Yep.
Who's flattering who, though?
I'll take it either way.
Thank you so much for listening and joining us on our journey of collaborative healthcare.
Please do smash the like button, send your comments in, and make sure that you're subscribed so that you can see the next episode drop.
Thanks again to Dr. Tash Mirando and to all of you for listening. And remember, sleep well, lift heavy weights, and focus on your quality of life. Take care.